We finally get to chapter 15, which is psychological disorders. And psychological disorders is the topic that most people think of when they think of psychology. So, psychological disorders include depression, anxiety, obsessive compulsive disorder, schizophrenia, and then all of the symptoms. Well, there's like 250 or so listed in the Diagnostic and Statistical Manual of Mental Disorders, which is developed by the American Psychiatric Association. The manual is over 1,000 pages long because some of it is like appended in or online, so you have to like read more about it, each disorder online. But that's what the topic of psychological disorders includes. But do know that the diagnostic manual and the disorders included in there is only one way of looking at psychological well-being and possible forms of psychological dysfunction. So in some countries, there's the use of the International Classification of Diseases, which defines a lot of the disorders differently and has a different idea of why the disorders occur. And those are just two examples of how disorders are considered. Some schools of psychology would argue that there are no psychological disorders. There's just differences in behavior and cognition, and those differences are defined as problems, but really they're just aberrations or something that's somewhat outside of the norm. So sometimes you hear the word abnormal psychology, but that doesn't mean that a person is born with some sort of impairment or problem. Most of these disorders are only called disorders if they present a problem to the person or their family. So let's take a look at what is included there. A couple of concepts and pictures of celebrities. So psychopathology is the study of disorders. So obviously pathology, the study of problems, the study of disorders or diseases, and the psycho part being diseases of the mind or diseases of behavior. And so a disorder is a condition characterized by something that falls outside of the norm. So again, we typically don't call it a problem if someone is exceptional with their social skills, but that would still be abnormal. So the exceptional. If someone has a social impairment, so they have difficulty building relationships, well, and it starts to influence their ability to keep a job or make friends, well, then maybe we could classify that as a psychological disorder, and we'd probably see that in the neurodevelopmental disorders. And I won't go into detail about those. It looks like fascinating pictures here. Openstax. These are three people who have red hair, and I think the point there is that they are. Oh, okay. So the point they're making is red hair is not normal. So a minority of people have red hair. I have a red beard, if you can tell, but that's pretty unusual. But that doesn't mean there's anything wrong with it. So abnormal may sound like a problem, but it simply means that something isn't common. It's not usual. And in some cases, that uncommon trait becomes a problem for a person or their family. That's when we get into psychological disorders. I had misunderstood. I thought they were talking about the genetic, red hair is genetic, and that some disorders are genetic. No, that was my mistake. That's why I was criticizing those pictures. All right, so what is a psychological disorder? Okay, I'm happy that Openstax includes this. A lot of what qualifies as a disorder has to be interpreted through a cultural worldview. So for example, if you live in an area such as the American South or like the Baptist region, and you're at a Pentecostal church, and a Pentecostal church members believe in like the fruits of the Spirit. So there's speaking in tongues, for example, and this is the idea behind that is you're filled with the Holy Spirit and you speak the language of the angels. And it doesn't sound like English. It doesn't sound like any established language. It's this very peculiar language. If you were to speak like that in a university classroom, like a public university classroom, everyone would look at you like, that is strange, you're not communicating, and that would get the abnormal thought or abnormal speech symptom of schizophrenia. You're exhibiting these abnormal speech patterns. But if you do the same thing in the context of a Pentecostal church service, everyone would look at you as being filled with the Holy Spirit, that you're a very holy person. You have this relationship with God, and God has given you these gifts. So in that the very different cultural contexts, and in one, you would have a symptom of schizophrenia, but in the other, you would have a symptom of holiness, a symptom of spirituality, and that wouldn't be a disorder. So culture helps define what qualifies as a disorder and what qualifies as order. There's a concept pulled here from Wakefield, and that's what I referred to earlier. So a disorder is only a disorder if there's a dysfunction. So just because it's abnormal doesn't mean there's a dysfunction. A dysfunction occurs when an internal mechanism such as thinking, seeing, learning breaks down and cannot perform its normal function. So in other words, it presents as a problem to the person. So plenty of people can satisfy, hello Adelaide, plenty of people can satisfy the definition of depression, for example, but if it's not presenting as a problem to the individual or to their lifestyle, then there's no reason to diagnose them as such. So it's really important that there is some experience of harm, at least from the person's perspective at least. Okay, so the American Psychological Association is listed here. Now, I would gather, so there's the American Psychological Association. They're responsible for training clinicians and kind of defining the curriculum for psychology students and future practitioners. What I mentioned earlier, the diagnostic manual, that's published by the American Psychiatric Association, which has a lot of physicians and medical providers and neuroscientists, along with clinical psychologists. So here we're getting a definition from the American Psychological Association, and a disorder is a condition that includes the following: disturbances in thoughts, feelings, and behaviors outside of cultural norms, some kind of biological, psychological, or developmental dysfunction, and a significant distress or disability in one's life. So you have to have those three components qualify or checked in order to qualify for a psychological disorder. Still, there isn't an agreed upon definition or boundary between order and disorder. In fact, the first 100 pages or so of the diagnostic manual talks about how these categories were developed and how there's a lot of overlap, and it's not really clear what qualifies as a symptom, what doesn't, what qualifies as dysfunction, what doesn't. There's a lot of gray area. It's not black and white. So if you're ever going to use the manual, make sure you read the preface and introduction. It's very, it'll open your eyes a bit. Okay, so here we're talking about the DSM. The DSM is like, I don't have it with me, is like a medical manual, and it has all of the symptoms of every disorder, like over 200, and the symptoms included, how they tend to manifest, how they present, some of the common problems associated with it, and then the percentage of how many people, like in the world or in a given country, exhibit those symptoms or exhibit the disorder. So that's why it's the diagnostic. It provides diagnostic criteria, and it's statistical. It provides the numbers of how many people have been diagnosed, like each year, or in a given year. So I don't expect you to read that if you're just studying as a intro to psychology student, but if you see a future for yourself as a clinician, a counseling psychologist, a therapist, you'll probably want to pick up a copy. It's expensive, unfortunately, and just kind of thumb through it. Read about depression, read about anxiety, get a feel for how it's written and how it's used. It might be intimidating at first, but it's really rather straightforward and easy to use. Here we have some stats from the previous version of the diagnostic manual. So this was DSM-4. And so it has over here on the left major depressive disorder, alcohol abuse, all the way down to dysthymia, which is sadness. So we've got males, females, and total, and these are percentages. So it looks like major depressive disorder in this list is the most common, where you have females affected a little bit more than males, about 30% more than males. And the average, about 17% of, and I'm guessing this is adults, suffer from major depressive disorder. And I was reading here, it looks like, yeah, so we're on the DSM-5 now. In fact, we're on the DSM-5 text revision. So that happened in DSM-5 came out in 2012 or 2013, and recently, in the last few years, we have the text revision. But anyway, you get the idea. We can look at statistics of disorder diagnoses in different demographics. Comorbidity is a confusing word. It sounds like death or co-death, but what it means is there's an overlap between disorders. So here we have a person with obsessive compulsive disorder and a person with major depressive disorder, and there's a likelihood, about a 41% of the group overlaps. So like 41% of people with major depressive disorder also have obsessive compulsive disorder. So it's unclear whether one's depressed, and that leads to like solutions through obsessive compulsive compulsions, or the problem of the compulsive behavior leads to depression. But what we see is a lot of overlap. So is that because we don't have clear definitions between these disorders? Possibly. Is it that one leads to the other? Possibly. It's not entirely clear the way that the DSM has been organized. I mentioned already the ICD. You can read about that there. This is going back in history, supernatural perspectives, psychopathology, problems of the spirit. There was a belief that abnormal behavior, so someone unable to speak in complete sentences, like they're going crazy, so to speak, the belief was they were inhabited by an evil spirit, and in order to cure them, you had to let the spirit go. And so the practice was called trepanation. I'm wondering if that word is listed on this slide. I don't see it, but one of the solutions was to drill a hole. That's what they're doing here. Drill a hole into someone's head and then let the spirits out. Trepanation is what that was called. I don't know about this. Dancing mania. In the medieval European era, there were groups of people who would just start dancing like crazy, like a rave maybe, for days or weeks, and screaming of terrible visions. And it was attributed to supernatural forces. Now we know that that's a social phenomenon. So if a bunch of people just started dancing spontaneously, we've seen things like that on YouTube, maybe like TikTok, where someone will plan like a dance and a bunch of people will get involved. We wouldn't call that a psychological disorder or even a spiritual problem. It's a social phenomenon. But anyway, in the history, we thought it was, the medieval scholars thought it was something spiritual. All right, now it looks like we'll look at a couple of different explanations for why disorders happen. One of those perspectives, and in fact, one of the strongest perspectives in the most recent version of the DSM, is that disorders are biological. They're caused by, in this example, genetics, also neurotransmitters, the presence or absence of neurotransmitters, neurological development disorders, so nervous system tissue didn't grow in the right way, or it's not being used in the right way, endocrine problems, so hormones kind of being out of whack. But this slide looks at genes, and it looks like if people have, so this is for schizophrenic individuals, schizophrenia being one of the most extreme psychological disorders you can be diagnosed with. Identical twins who have been raised separately, I'm guessing. It doesn't say that. So identical twins have about a 50% likelihood of sharing schizophrenia or manifesting schizophrenia. And so that would suggest there's a genetic component between some psychological disorders. But that's just one way of sort of understanding why a disorder occurs. Another um, another model is the diathesis stress model, and ultimately, it's just the idea that we can only handle so much stress. And so, like, we start a new job, and then our partner breaks up with us, and then our mother dies. And it's like once we get to a certain threshold of stress, we break. And then that break will manifest as like major depressive disorder, anxiety or panic disorder, maybe obsessive compulsive disorder or personality disorder. And so it's the idea that um, there is maybe an increased genetic likelihood that you'll become depressed, but unless there's been precipitating factors in your life, it may never happen. So if you come from a depressed family or a family with alcohol use disorder, then there's a chance that you will also develop depression or alcohol use disorder, provided there is enough stress in your life to make that happen. So there has to be two components: the stressors that lead to it, and then the genetic predispositions, diathesis and stress. All right, so the DSM, and I'd like to have a copy here, but I don't know how helpful that would really be. But it's divided into a whole bunch of sections, and each section, such as anxiety disorders, has, I think for anxiety disorders, maybe 10 or 11 different types of disorders that are related to anxiety and fear that you can have. In this slide, and I just wrote an article about this, differentiating fear from anxiety, so it's not really super clear in the DSM, but fear is understood. So this is understanding what anxiety is, but fear is defined as a threat in your environment. So like my dog's sleeping right here, she's no threat. But if all of a sudden she thought I was an intruder and she started like growling at me and baring her teeth and like getting ready to strike, then I would be afraid of her. Like I would have a fear of something in my environment. But if she's just sleeping there and I worry that what if she were to turn on me? And so I'm afraid of something I'm imagining. So now it's in my, it's not actually happening, but it could potentially happen. That worry, that fear, that's anxiety. And so fear is a reaction to something that's actually in your environment. Anxiety, it's less clear what it is you're getting worked up about. So a whole bunch of different anxiety disorders. It looks like 25 to 30% of U.S. population has one of these disorders throughout their lifetime, more common in women than men, and it's the most frequently occurring class of mental disorders. For example, in the list of anxiety disorders, we have specific phobias, and those are extreme fears of something. So fear of heights, flying, spiders, enclosed spaces. I'm sure you've heard of those. There was the belief, this is quoted from 1977, but going back to 1925, Watson and Rayner's study of little Albert, that phobias are learned and they can be taught and therefore unlearned or untaught. Social anxiety disorder is what most people talk about when they say I have anxiety. And so that's this preoccupation with what other people are thinking of you, whether they're evaluating or judging you, whether or not you feel like you're playing a role or you're performing. All of those deal with social anxiety. 12% of Americans experience this in their lifetime. My guess is that is with my generation and Gen Xers, so millennials, Gen Xers, and boomers, I guess, whoever came before them. Gen Z, I have observed, and others around the country and world have observed, Gen Z has a lot higher incidence of social anxiety disorder and anxiety more generally. My guess is that number would be closer to 30%. And I actually have data to back that up, but you can read about that. Just type in anxiety and Gen Z, and I've got an article about it, and a lot of stuff has been written about it. But take a look at that. So that number is a little bit low for now, and I'm guessing who comes after Gen Z slipped my mind. But whoever's following Gen Z, I suspect there's going to be just about as high as Gen Z's for anxiety. Panic disorder is the onset of a panic attack. And a panic attack is hyperventilation, an inability to cope with something that's happening right now. You usually feel like you're out of breath, you can't breathe, tightness in your chest, inability to focus, you just kind of spiral downward. And this is an extreme sympathetic nervous system response. And it's dysfunctional because it doesn't actually help you out at all. And so oftentimes, anxiety, generalized anxiety disorder, just general anxiety, is fear of having a panic attack. I'm worried that if I go out in public, I'm going to have a panic attack, so I can't go out in public. And so panic attacks are very debilitating. They're very terrifying. I've written a little bit about that. Panic disorders, what causes them, looks like they're about 43% genetic. There's theories that it is a neurological dysfunction, that you've been conditioned, or there's a cognitive theory. So you're kind of interpreting what's going on in your body, and that has a feedback cycle that makes it worse and worse. Ultimately, we don't know. All we can do is make hypotheses and test those. Generalized anxiety disorder, I mentioned already. I'm not going to go through all of these, but you get the idea. There are like slight variations between each of these anxiety disorders, but we've got other mood disorders to look at and personality disorders, so I'm going to move forward. Obsessive compulsive disorder, I'll stop on for just a second because it's kind of a popular, or like one that people are curious about. So there's two parts of this. One is an obsession, that's a mental preoccupation with something, and the other part is the compulsion. So it's possible to be obsessed without acting on the obsession. So that's just obsession. You can have obsessions and be diagnosed with obsessions even if you're not doing anything. Or you can have a compulsion where you have to like act on something. You have to do some behavior usually, or obsessions are thought related, compulsions are behavior related. So it might be one of my favorite authors, David Sedaris, has obsessive compulsive disorder, and he writes about this in some of his essays. But he'll be like sitting in an airplane, and he'll have to touch the person in front of him's hair. Like there'll be a little hair sticking up, and he just has to rub the person's scalp. He can't help it. And so he writes about how ridiculous that is, but how natural it seems to him that he's just got to contrive ways of like touching someone's scalp. Or I think that was one of the examples. But imagine like being so consumed with this idea that you have to behave in a way just to like satisfy that itch. So a very small minority of the U.S. population experience that. I've actually been reading a lot about obsessive compulsive personality disorder, which isn't that level of intrusion. It's more of a way that personality is organized around productivity. So that's one of my issues that I deal with. And I don't know if there's a slide about it, but maybe I'll talk about that when I get to personality disorders. Common personality disorders would be like washing your hands if you've been around other people, but not just washing them one time, washing them like 15 times or 25 times. Usually if you get diagnosed with one of these disorders, it's not just some understandable or what's a good word? Reasonable behavior. It's unreasonable, and it interferes with your life. So I missed class because I had to double check that I locked my office door 100 times. I can't do that every time I leave my office. I'd never get anything done. Body dysmorphic disorder is something else that I and other long distance runners have suffered from. That's this idea that when you look at yourself, there's something wrong with you perceive there's something wrong with you, even if everything is normal, like there isn't anything unusual. Being preoccupied, for me, it's like weight, but being preoccupied with something wrong with your face, even if like no one looks at you and thinks there's something wrong, but you always look at yourself and you think, oh, there's this thing I need to fix, and you're always worried about it. And so maybe you keep getting cosmetic surgery, or for me, like I would exercise compulsively to try to like fix my body, or what I believed needed to fix my body. So that's just as, I guess, unusual as obsessive compulsive disorder, but it can manifest in a couple of different ways. Hoarding disorder, it looks like they picked out all the ones that are popular on television. The inability to let things go, or to get rid of things even if they have no sentimental value, that's another actual symptom of obsessive compulsive personality disorder. So what causes these things? Are those all? No, they're not listed as OCD, I don't think. What causes OCD? We had the same kind of hypotheses and theories that we saw earlier with anxiety or panic disorder. I'm going to skip those. I'm going to skip that. Another popular disorder is post-traumatic stress disorder. It's become popularized with the growth of veteran psychology, or the psychology of people who have been in combat, or at least who have been deployed abroad, or even just gone through basic training. The U.S. has a lot of people with PTSD, at least former military, more so than any other country, as I understand it. Now, in order to have post-traumatic stress disorder, or to experience trauma, the way that's defined by the APA, is you've experienced something where you were in real danger, or you imagined that you were in real danger, is one part. And then the other part is it doesn't have to be an immediate emotional reaction. It can happen months or years later. It used to be the case that you needed an emotional response at the time, but I guess clinicians have recognized that zero emotional response is also like a form of dysfunctional response. But anyway, some of those symptoms are listed here. You can read about them. There's a whole bunch of risk factors associated. So these would be the diathesis part, how likely someone is to develop PTSD. We've got more theories. Again, they're the same kinds of theories you see in all of the disorders. So you can imagine a whole different schools of thought related to psychological disorders, and they have the same interpretations no matter what the disorder is. Mood disorders I would expect to be quite a bit higher on the list, but that's where you have depression and mania, the opposite. Depression is usually marked by feelings of dysthymia, or the inability, I think the word is dysthymia, the inability to experience pleasure or joy. So it's like a feeling of sadness and some of these other symptoms like changes in eating, changes in weight, changes in sleep pattern, changes in social activities and hobbies. So there's usually life changes involved, and then feelings of like malaise, sadness, lethargy. Mania is like the opposite, where you feel invincible, you can do anything, so you stay up all night and like work really hard, and then eventually it catches up with you and you're like exhausted, and then you go at it again. Here were some of those symptoms. So the depressed mood is necessary, and then here are a bunch of the symptoms: fatigue, feelings of worthlessness or guilt, difficulty concentrating, thoughts of suicide, changes in weight, etc. I'm pretty sure like current college students know all of this better than even like a PhD in psychology. There's a lot more social awareness about mood disorders today. Last time I checked, there were like 15 subtypes of depression. I don't know if that was revised for the DSM-5-TR. I'm not going to go into bipolar disorder, but that's when you have mania and depression, and they alternate. Here we've got the same genetic, hormonal, probably cognitive, neurological, brain, and diathesis stress models for depressive disorders and cognitive. I'm not going to go into suicide because that's morbid. All right, finally, hopefully, is schizophrenia. And so schizophrenia is the most extreme and perhaps most bizarre psychological disorder. And there's 5 categories. The first and perhaps most common is hallucinations, so seeing something that's not there, hearing something that's not there, smelling, tasting, touching something that's not there, the hallucinations. Now you can have schizophrenia without hallucinations, but they're usually the most noticeable. Delusions are when you believe something in the face of evidence to the contrary. So you believe that something will happen, it doesn't happen, and you still believe it's going to happen, like someone's out to get you. And there's no evidence that they're out to get you. Those are uh, persecutory delusions. It's not listed here, but that's one of the more common ones. Um, A Beautiful Mind was a movie that came out in the 2000s, in the aughts, I believe, where Russell Crowe plays a brilliant mathematician who has persecutory delusions. He has schizophrenia. And it's a brilliant movie because you live with him. You see his persecutory delusions, and they all totally make sense, but they're not happening. There's no evidence that they're happening, so they're hallucinations there too. But you don't know about them at the beginning. Sorry to give that away. Disorganized thinking usually manifests as disorganized speech because you can't really see thoughts. Disorganized or abnormal motor behavior, when you behave in a very peculiar way. So it's like a social moray. You do something that no one would do in that circumstance. So everyone's like, why are you doing that? I have some examples for myself. I'm not going to share them. Negative symptoms. These are the absence of feelings or behaviors and social actions that you would expect to see, but they're not there. So lack of motivation, lack of speaking, lack of social contact, lack of pleasure. I've had a student who exhibited lack of affect, so that's not on there. What was that called? I forget which word that one is. But I guess alogia, reduced speech output, but also lack of affect. I think it's just called flat affect, where she would answer a question and be totally monotone. And it was almost funny because she never had any sort of vocal expression. And we were going over that, and she's like, that sounds like me. Like she had this recognition, and there wasn't any like inflection in her voice. She's like, that sounds like me. I said, yes, it does. What causes it? We've got the familiar genetics, neurotransmitters, brain anatomy, events during pregnancy, possibly. Dissociative disorders, dissociative identity disorder, for example, is another popular one. If you've seen the movie Split, which is about this psychopath with, I think, 24 personalities, something like that. My students got a kick out of it. He had dissociative identity disorder, so he had multiple identities he was living with. So the dissociation is part of who you are is kind of split off. So it is still you, but it's split off, and you're like, that's not me. But that personality still has a role to play, and so when you play that role, you're like not even aware of it. You black it out. Can that happen 24 times? The evidence of dissociative identity disorder is very slim. It's more a social phenomenon people talk about and get excited about. And a lot of the diagnoses didn't happen until it became popularized socially. Here we have a whole list of personality disorders. And so again, this is relatively constant personality traits that are abnormal and lead to problems. And so we've got cluster A, cluster B, cluster C. Cluster A I'm not familiar with these organizations, but it looks like cluster A is the most severe and needs the most care. Cluster B can get you into some serious trouble, but can also be used to your benefit, but maybe are the most dangerous. And then cluster C would be the most common. Yeah, antisocial and borderline personality disorder are the most problematic. So those are in cluster B. So borderline personality disorder is when usually based on someone who's had a bad childhood where they do not trust their caregiver. So there's this like lack of trust in the world, and then that manifests in some pretty unhealthy ways. So show intense and inappropriate anger, impulsive. So making choices that are self-destructive, spending all your money, having frequent and unprotected sex, driving carelessly, all of those things can be problematic. But combined with some of these other things, unstable relationships, unstable view of self, as you can imagine, there's not a whole lot of consistency or constancy in that person's life. And then that can manifest in all sorts of problems, including murder or suicide. What do we got here? All right, so here are, antisocial. I thought we were still on borderline. Antisocial isn't I like to be by myself. That's asocial. Antisocial is I enjoy watching people in pain. So, people, children who torture animals, usually a pretty good indication that they're antisocial. And then enjoying picking on others, like bullying others for reasons of just joy and fulfillment, not other like ways of dealing through psychological trauma. But this is like, I like seeing people suffer. That's antisocial personality disorder. So you can see some young symptoms, teenage, and then adult symptoms. Familiar causes and theories. I'm kind of getting tired of this topic, so I'm going to skip through these. ADHD is a neurodevelopmental disorder, along with autism and a few others. So you can read about that one here. That's one I like to take my students through and actually read the symptoms in the DSM and kind of wonder how much of these are pretty normal, even though they don't fit in like a elementary school. So a lot of these symptoms only matter because of the way we organize learning. Causes, autism spectrum disorder. I've written quite a bit about that too. It's a very fascinating topic, particularly because we've just combined a bunch of disparate categories into one. And there's a lot of variability in that spectrum. I'm not going to read this, but I'm guessing there is no evidence that there's a relationship between vaccinations and ASD. And that's it. I've reached the end. All right, so that those are disorders, and next up, the final chapter is treatment. So if you do have a disorder, there are a variety of ways to treat them. We'll take a look.